Hello everyone, welcome to the new subject which is anesthesia. So before you start learning about anesthesia, first learn about the drugs which I taught you in the earlier lectures. So it will be easier for you to learn anesthesia because in anesthesia we use different kind of inhalation agents, IV drugs agents. So it will be easier for you if you know some of the drugs and then you will start this learning. Okay, let's start the new subject which is anesthesia. So what anesthesia do? If you are giving anesthesia to patient, what it will do to the patient? First thing, it will make her or his pain relief, then muscle relaxant, then he will be unconscious and he will have no memory of the operation or whatever we will do for his like any operation we are doing to his body. He will not feel any pain, he will be unconscious, due to unconscious he will not have any memory and his muscle will be relaxed, so we can do operation easily. Okay, so there are three types of anesthesia. First is general, then second is regional, and third one is monitor anesthesia. So everyone has their own qualities. For example, general anesthesia. In general anesthesia, if we give the anesthesia to the patient, his full body will be paralyzed, his full body muscle will be relaxed, and then he will have no memory of the operation or whatever we are going to do with him. He will have no memories. Okay, and he will feel no pain. But in regional anesthesia, there is one different thing. He will be awake, he will have the memory, but he will not have the pain. For example, I can give you, a lady is there and she is going to deliver her baby, and when the delivery time came, she is not able to bear the pain of the delivery. So doctor gave her lumbar regional anesthesia. So when doctor gave her the regional anesthesia, her lower body parts like her legs and the vaginal part, she will not feel any pain. But her upper body will be awake. She can see the operation, she can see the delivery of the baby, and after delivery she can hold her baby and she can feed her the baby. So this is the benefit of regional anesthesia. For example, a patient got injured on the hand. So he told the doctor that I don't want to get paralyzed, and I have anxiety and I have some problem. So just give me anesthesia to my one hand. So doctor what will do? Doctor will block his nerves of the right hand or left hand and he will do the operation. So this is the benefit of regional anesthesia. Okay, and what is monitor anesthesia? For example, in monitor anesthesia, there is one grandma came to your hospital and your doctor want to do some procedure of her mouth, or we can say some he want to give sutures, or sometimes he want to remove her teeth, or he want to check his some body parts, and that time that grandma feels anxiety or her heartbeat got increased. So doctor tell you that anesthetist just have a look at that monitor just the grandma the heartbeat and other things, so I can do the procedure very well, because if anything wrong happens, so anesthesia will take part and will be solved, the problem will be solved. And if anesthesia doctor will not take part in that and some problem happens to that to your lady, the doctor will be punishable. Okay, so this is the benefit of general, regional and monitor anesthesia. These are the three different parts of anesthesia. Okay, so the next part is pre-medications. Like pre-medications, before giving, like if you want to give a person anesthesia, before going to give him anesthesia, some medication we have to do. Okay, so for example, for anxiety we can give midazolam. Okay, antacid we can give pantoprazole or ranitidine, which we use normally. Then analgesics, like he said, doctor, after last time my operation was there and after that I was feeling so much of headache and I was feeling vomiting and I was having some nausea and another like anxiety after the operation. So to stop that thing, we can give prior medicine, which is like I told you about these three medicine now. And for decreasing salivation, because a patient has more saliva, if you are awake your salivation will be there, and if you aspirate your saliva during the operation, it can form pneumothorax in your like pneumonia you can happen in your lungs and the fluid can get collected in your lungs. So to stop the salivation, we give anti-salivatory drugs which are atropine and glycopyrrolate. Then antiemetics like ondansetron, like vomiting drugs are there, like ondansetron and other drugs are we can give. So these are the pre-medication. Before giving anesthesia, we give these medicines. Okay, so now we will learn about color coding cannulas, like IV cannulas, which we use in our anesthesia. So there are all these cannulas are there and different gauge are there. So what you are seeing, the numbers, these are the gauge. So remember one thing, smaller the number, bigger the flow of saline it will be given by the cannula. So smaller the cannula, higher will be the saline it can give to the IV line, like in the bloodstream. Okay, so orange, green and grey, these three which we use in trauma. Like for example, accident happened and that time patient is in shock, so that time we have to maintain his fluids, so we will give IV. So that time these three IV mostly we use. And in children's, like small baby, pediatrics means small children's, so you use yellow and purple. So how you will remember different kinds of different cannulas and its gauge? So just have an imaginary now with me. For example, earth has a core of lava, so lava is orange. Okay, lava is orange. Above lava there is soil is gray. After on the soil there is a grass like green. Okay, on grass there is a pink flower. After that pink flower there is a blue sky. On that blue sky yellow sun is there, and afterwards purple rainbow is there. Like this, imagine in your mind and you will remember all the kind likes. Like orange, like lava means orange, then gray means soil, green means green grass, then pink flower means pink granula, after that blue, then sun yellow, and rainbow means purple. So you can remember 14, 16, 18, 20, 22, 24 and 26. Like this you will remember all the IV granulas, and it will be easier for to remember. Like 14, 16, 18 granulas are used for trauma, and whereas 24 and 26 used for children's. These are the all granulas we use in our anesthesia. Let's move to the next part, which is monitors, which we use by American Society of Anesthesia. These 5 attachment we do usually on our anesthesia or in our OT. For example, oximeter. I think in COVID time everyone know what is oximeter. Okay, so we place our oximeter on your finger or in your earlobes or at the tongue. Okay, if a patient is don't have his hands, you will say how you can put oximeter. You can put on the earlobes or you can put on the tongue also. Okay, then everyone we know we use non-invasive blood pressure machine. I think most of the families have in their homes ECG to monitor his heartbeat, then the body temperature, and the capnograph. Capnograph is used for usually for CO2 output in our body. Okay, so all this we can see on the monitor, which is all the parts are attached to our body, and all things we can see on the monitor in our anesthesia room. So let's study how most of you see this in your operation theater. So what are the things in that? We don't know. We just look at the things and we'll think what are they. So let's study today and we'll remember it for forever. So first, as you can see 62, it is your heart rate. Okay, after that on this side you can see ECG. The next part is your blood pressure, non-invasive blood pressure. There are 2 types of blood pressure. One is invasive and other one is non-invasive. Okay, so as you can see downward here, after non-invasive there is invasive blood pressure. This CO2, as I tell you about capnograph, and these are the capnograph. As you can see, this is normal one, 27 its number. Okay, these are the capnograph. We will gonna study different types of capnograph also. So before we'll learn about regional anesthesia. As I told you, regional anesthesia. In regional anesthesia there are 2 types: central, neural and peripheral. So in spinal we give epidural block, and in peripheral we do femoral and brachial block. Like there are the parts you can, I think you know about the femoral and brachial parts which we give anesthesia. Okay, monitor care. Okay, this also I told you about monitor care, what we check about the risky patient like ET or grandma is there and what we check. So this also I think I told you in the beginning. Let's study step of the anesthesia. So your patient has given the pre-medication, you know about your patient. Now you are gonna give you are gonna do the general anesthesia to the patient. So what you will do step by step we'll learn now. Okay, first you will give pre-oxygenation. Okay, because once you will get unconscious you will not breathe by yourself. Okay, so there will be some time that you will not breathe until, because the doctor will do his intubation in your mouth. So there is a time, some period, there is a small gap of 3-4 minutes, so you must survive that time. So we will do pre-oxygenation. 100% oxygen is given for 3 minutes to replace nitrogen with oxygen in our body. So we'll give 100% oxygen in our lungs, so our lungs will be full with oxygen, and it will give time to the anesthesia to do intubation in your for your mouth. Okay, first thing we'll do pre-oxygenation, then we'll induce our anesthetic agent. First we give IV route, preferred mostly IV route if small babies are there, so you can't give because they put your hand like this all the time. So for small kids we give inhalation. Okay, so these are the 4 drugs which you: thiopenton, propofol, ketamine and etomidate. These are the drugs which we use for IV anesthesia. And what are the drugs are used for inhalation agents? As I told you in the pharmacology anesthesia chapter about these drugs. Now these are drugs useful here, like sevoflurane, halothane, isoflurane and desflurane. Okay, so about these drugs, they will block GABA receptor in our brain. Then once you give pre-oxygenation, you give IV agent, now your patient will be paralyzed. Your patient will be paralyzed by NM blocking agents like ACH and reconium. Then you will do intubation. The 4th step will be intubation. You will put your oxygenation tubes. Okay, then you will attach that intubation, whatever you put, like you put oxygenation tube in your mouth, and you will put that oxygenation tube to the ventilation machine, so it will give you oxygen continuously to maintain anesthesia. Okay, so to maintain anesthesia, like once I give you the anesthesia by your vein, okay, now you are unconscious, but after sometimes you can awake during the operation, so I have to maintain your anesthesia throughout the operation. So what I will do, I will give oxygenation plus nitro oxide, and there will be some anesthetic agent with it like isoflurane or sevoflurane or dexoflurane. Like these are the gases which will carry the anesthetic agent in your lungs. By lungs it will go to your periphery, and your whole body will be stay in the anesthesia during the operation. So once the operation, after like 3 hours, your operation is finished. Now doctor told me that operation is finished and the patient must become unparalyzed. Now to end the operation and to make unparalyzed, we'll give reversal agent, neostigmine and glycopyrrolate. So it will be like you are unconscious, then we give you these drugs and you will be unparalyzed, so you can move your body and you will be awake after some time. Okay, and when you will be awake, we can exhibit, like first we give you the oxygenation tube in your mouth, but now we will remove the tubes so you can breathe by yourself. So these were the 5 steps which we do in anesthesia. Now before anesthesia we do some classifications, like for examples. Now we will do that classification. For example, there is a healthy person. What is healthy patient? Like he having normal heart rate, normal BP and everything is normal. He has no disease, okay, like diabetes or anything. But mild disease, like what are the mild systemic disease? Like the patient have hypertension but it is controlled. Okay, he had diabetes, he is taking insulin properly, so it is mild but it is under the control. Then third, which is moderate like moderate to severe, you can say. In that patient have diabetes, patient have hypertension, but it is not controlled. Like he is saying, doctor, I have high blood pressure, I have diabetes, but I don't take medicine on time. I forget sometimes. I take on Monday, I forgot on Tuesday, and again I take on Wednesday. This kind of patient comes in this category. Then severe. What are the severe? Like severe in what? He has hypertension, he has diabetes. When you check his hypertension, it is like 200 by 150 systolic by diastolic, and you are like, oh God, what to do? And he didn't tell you before the operation. So these are checked before the anesthesia, because if you don't know about your patient history, you can risk the patient's health or you can his life. So always take your patient history wherever you work in your OT time, you work in your own hospital, or you work anywhere in your life. Always take the patient history. He has some allergies, some kind of disease before any operations, or some allergies to the drugs. This always must be written in your book, so or in the paper, that you will remember that this patient has some problem, because one single mistake in your life, in your OT rooms, can kill the patient. So always remember that thing. This is come in the 4th grade, but in 5th grade, morbid patients, and these patients are like rarely they can be saved during the operation, and the last one is death. So first one is healthy, then second category is mid, moderate, severe, almost dead, and dead. So these are the classification of anesthesiologist. Okay, so fasting guidelines. What's fasting guidelines? So doctor told you that you have to come tomorrow morning for the operation, and as I know, always you had told that don't drink any water, don't take last night meal, or how much time there must be there to come to the operation, and what time you must do fasting, like you have to not take some food or water during the operations or before the operation. Always we go to the doctor and doctor will tell at least you have to take food 8 hours before the operation, after that you can't take the food. So why doctor tell this? No, for example, if you have heavy meal and you eat so much of burgers and everything during the operation, that whatever digestion has been done in your body can come out, because your body is paralyzed. So your splinters which stop the like this is your for example, this is your esophagus, okay, and there are splinters which stop the gastric juice to come out from here. But when you are paralyzed, this splinter will be loose and the juice will come directly to your mouth and it will go to your lungs. So doctor tell do not take any kind of food or milk before 8 hours or 16 hours before the operations. So we'll know what are the procedure for this. Like full meal you can take 8 hours before, after that you can't take. Like light meal like cow milk, or light meal like you are taking some chai and some few bread, 1 or 2 bread, then, or you can take snacks. Breast milk, like if a small kid is there, how you will tell that 8 hours don't give any milk to the baby will die. So for babies it 4 hours, like before there is operation after 4 hours, so before 4 hours you must take, do not feed the baby. And liquid, you clear liquid, like clear liquid means water, not any juice, clear liquid means water, and it can be taken 2 hours before the operation. So these are the things you must do in the fasting during the before the operations. So these are the fasting guidelines of anesthetic. Then Malam Patti classification. What is the Malam Patti classification? So whenever you have to do intubation for the operation, that time you check patient's intubation, like how you will do. For example, there is a classification of Malam Patti classification. So you will tell your patient to put 3 fingers in his mouth. If he can put like this, so his mouth opening is normal. In that you can see uvula, you can see this glands, and you can see the opening is clear. In second one you can see this tip of the uvula. Here you can see big piece, here you can see small piece. In third one you can't see the uvula, and in the fourth one as you can see it is more difficult. So bigger the opening will there. In first patient you can see his vocal cords, uvula clearly, so you can do intubation very easily. In next patient there will be little bit difficult. In third patient you can't see, and this time you have the problem because you gave patient the anesthetic and he is paralyzed, and you have to do intubation because he will die without oxygen. So that time this can make your problem more worsen than anything. So always check this, that your patient opening is clear, mouth opening is there, because there are some people who eat gutkas and we can say some kind of the things, they don't like smoking everything, that's why their mouth don't open and it will become difficult during the anesthesia. So always check this. So there will be question, which intubation is difficult to do? Fourth one is the most difficult, and if fourth one is not there, third one is the next one. Okay, and these two are normal one. There is one more classification, same as like Malam Patti, which is Conmack and Lange grading. As you can see, there is vocal cord opening little, and here you can see the vocal cord opening. Okay, so these are the classification where you can check the opening of the mouth for intubation. Now the next part is pre-anesthetic order regarding medication. So what medication must stop before the operation? Okay, so these are the list of the drugs which must be stopped or can continue during the operation. So first is AC inhibitors, ends with pills. Okay, so emit on the day of surgery. So on which day you have the surgery, at that day you should not take AC inhibitors. Then angiotensin blockers, then diuretics, then beta blockers, calcium channel blocker, central acting alpha 2 agonist. So this 4 you can continue till the morning of the surgery. Okay, these 4 drugs you can take. So and this you have to emit, like this 2 drugs have to stop before the day on the day of surgery. Then, for example, there is a diabetes patient and which is on insulin, like he is taking insulin regularly. So already on the day of operation, he will on the fasting, so there will be already low sugar in the body, and if we take insulin, more sugar low will be there and it can cause hypoglycemia. So on that day you are already starving, like you are not having any food and still you are taking the insulin, it can make the problem, so it can make hypoglycemia. So you must not take this medicine on the day of surgery. The next one is antipsychotic, anti-epileptic, antidepressant and anti-anxiety. This medicine should be continued. Why? For example, there is a psychic patient is there and we have to do some operation of his body, and due to psychiness, if you stop that medicine and before he will come to the hospital and that time he got his mental shocks back or his mental condition worsen, that time it will be a big problem for the hospital, that he will throw things here and there, he will shout and he will do something wrong for himself too. So that time this medicine must be continued, because it can make problem for patient also and the hospital team also. So this medicine must be continued. But there is exception for one medicine, which is lithium. You should not take lithium on the day of operation. You should stop lithium 48 hours prior, like 2 days before the operation you must stop the lithium. Okay, and this second one, I think this is no need to learn for you. The next one is thyroid disorder. Okay, there are thyroid medicine, so you should continue your thyroid medicine, because it will make thyroid patient athyrotic. Like if you give thyroid patient, it will swallow and it will make more difficulty for the oxygen esophagus, like it will make difficult for the oxygenation. So you must continue if you have hypothyroidism or hypothyroidism, you must continue that drugs on the day of surgery. Then are OC pills. So OC pills, if you have low risk of deep vein thrombosis, you can continue on the day of surgery. Then patient receiving oral steroids. If you are having oral steroid going on for the medication, he can continue on the day of surgery. And then the last one is if a patient have going under the tuberculosis therapy, he must continue the drugs. But before you can do your pre-anesthetic checkups, you should always take liver function test. Okay, so you must do liver function test as your pre-anesthetic checkups. Now this medication you just remember, because every time there are questions for on this, like aspirin, prodrugil, warfarin, heparin, lower molecular weight of heparin and ticlopidine. So this you can just rectify and learn and remember, because there is no alternate for them to remember. You have to just mug up them, because every time there is a question on this subject, on this only, because one question will be there always in the exam, that which drug you should not take or which drug you should take on the day of surgery or in anesthesia. This you must remember. Now the important part, which is capnogram. As earlier I told about capnograph here, as you can see here in the machine. This what we are going to study now, capnogram. Okay, this. So let's start about capnograph now. So as you can see, this is capnograph, graph is there. Okay, here first page, second, third phase and the fourth phase. What capnographs tell about? It tell about CO2 expelled in our body or inhaled in our body. So here inspiration and expiration, as you can see. Inspired carbon dioxide and tidal carbon dioxide. So usually it is seen on third, like ETO2 value is taken at the end of the phase 3. There are first phase, second phase, third and fourth phase. So usually it's taken on the third phase. So you can remember, like first phase is inspiration, second phase is expiry of stroke, third phase is alveolar plateau, and then beginning of the next inspiration. Okay, so remember this diagram, it will help you. Now we'll study of different kind of capnographs. So this is the normal capnograph you are seeing. Now we'll see different kind of capnographs. Okay, let's start with the first. Okay, a patient undergoing abnormal a patient is going under a patient undergoing abdominal surgery under halothane suddenly shows increase in the E2 or CO2 from 40 HMD to 100 HMD along with the increase in the core body temperature to the 40 degrees Celsius. What is the diagnosis? As you can see, the capnograph is rising, this, then this, then this, and this. So it is a like step ladder pattern. You can see increasing the graph, step ladder pattern is this malignant hyperthermia. So always remember, if the graph like the capnograph is like step ladder pattern is showing that it is malignant hyperthermia. Okay, so let's next. The first year of anesthesia residency intubutes a man undergoing laparoscopy after 2 unsuccessful attempts. Okay, on intubation, the capnograph looks like given below. As you can see, the capnograph is decreasing. So gradual decrease in capnograph. First gradual decrease, because first what we studied first, step ladder pattern. Step ladder pattern is malignant hyperthermia in the capnograph, and now this is decreasing, gradually decreasing, slowly. So immediately, and once he did anesthetic agent was like anesthesia person was there, he gave anesthesia agent, and now he is doing intubation of the endotracheal tube. So when he was doing that time, he looked that he did first 2 his attempt was unsuccessful. Now he gave the 3rd attempt, and after some time the capnograph started decreasing. So what is happening? He did esophageal intubation. Like in larynx, we must put in larynx or for oxygenation, but he put in the wrong place. He put in the esophagus, so all oxygen will go to the stomach and small intestine and large intestine. It will not go to the lungs. So what will happen? If lungs will not go to the, if air will not go to the lungs, obviously the capnograph will decrease. Okay, so increasing step ladder pattern for malignant hyperthermia, decreasing for esophageal intubation. Now the next one is the kind of shirt. You can see kind of shirt is there, like notch is there. Okay, this graph of a patient undergoing hysterectomy, general anesthesia. Okay, cleft is going on. Okay, patient is under anesthesia. So what you can do? So and when you will see like this type of M shape, as you can shape M shape, but I can see as a shirt always. So you can see this notch is coming. So at that time you should give a top up of anesthesia, because the patient must coming out of the anesthesia slowly. So you should give a top up. Okay, top up means you are giving more anesthesia to make him again unconscious and sleep in the or paralyzed. Then is shark fin pattern. We can see, as you can see, shark and his fins are there. Okay, so it is in bronchospasm. So patient is having bronchospasm, and that's why his capnograph is like shifted like this, like a fin. Okay, next one is sudden fall. Like it was going normal, that normal was going, and suddenly flat line came in the capnograph. What happened? Though it must be happened like accidental intubation, like the tube came outside from the mouth. Then cardiac arrest, the patient is having cardiac arrest, pulmonary embolism, and the last one is circuit disconnected. Like for example, everyone in the OT, everyone is running for the emergency operation, and suddenly someone kept leg on the intubation tube and it came out of the mouth, or it got blocked. So obviously if it will got blocked, the capnograph will directly decrease. So sudden fall in the capnograph. So this can 4 reason can be there. Then you can see again decreasing capnograph. Okay, so it is due to low blood pressure or blood loss, hyperventilation is there. So this is one kind of capnograph. So as you can see in this capnograph, the line is not touching to the baseline, it is little bit above. So it is happening due to rebreathing. Like patient is under anesthesia, but this kind of breathing he is doing in, like his oxygen is given to him, still he is breathing with his nose, and that's why this up elevation is shown. So you can give him again anesthesia, he will properly sleep again and he will not rebreathe. Okay, then you can see this kind of pattern in the capnograph. It is cardiac oscillation. So there are different kind of graphs, like in capnographs there are different patterns are coming, and you must remember this pattern, because these patterns are coming in the exam mostly, because in my last exam one of them came in the exam, and I think you must study this also, because by my mistake at least you should learn. I learned by my mistake, you should also be aware by this, and that you will not do this mistake in your exam also. So this was the first part of anesthesia complete here. Like cardiogram, this will talk about in the next part, because what are the chest lead and whatever leads we are using, it's already teach in our ECG part. If you know what are the leads, limb leads, chest leads, this also I taught in ECG video, but still I will taught you here. So we'll start this on the next part. Okay, for today that's it.